Heart disease in pregnancy. I'm going to start by saying, why is it important for you to know about it? Because a lot of people, it's a subspecialty, very niche area. I'm an interventional cardiologist by trade. I also do some ACHD. But essentially, the reason it's important is because the Embrace report has shown us that we really are struggling to manage these patients well, despite all the advances in cardiology that you've been discussing. We have, an Embrace is basically a triennial report which comes out on every maternal mortality in the UK. We're the only place in the world that has such robust data. And I would say it's worth reading the cardiac chapter because, to be honest, it's actually quite easy reading. And there are some statistics which I'll show you and which will upset you. But there are also vignettes, little vignettes that sort of basically summarise the whole story as to what the issues were. So it's not like one of these terrible textbooks that you have to, drain through. It actually is really worth reading, and it's not that big. So I would definitely say download it. They've got it on, you can just go now onto Google and you can PowerPoint slide download, and it's really easy to do. So why is it important? Well, the last report was basically released in December 2019. It was released a bit earlier to those of us that went to the release, but we had to embargo it until the general election, and which is one of those things, isn't it? But essentially, the reason is that cardiac disease is still the UK's biggest cause of maternal death. So if you think about all the advances that you've been listening to all week, the reduction in coronary artery disease, with all the advances in valve therapy, imaging, whatever you've been hearing about really significant improvements. And yet the maternal mortality in cardiac disease is still increasing. And you can see it's much bigger than things like thromboembolism, hemorrhage, the sort of things that people worry about with a pregnant woman. And essentially this is just showing that, we're not really making big inroads. So the mortality is still very small, and the mortality is so the tip of the iceberg. You really only see, a few cases compared to the huge amount of morbidity that Kate and I have to deal with in our clinics. The other thing is that normally when you say to people what the cause is, we think about all the complex congenitals. You've been hearing about Fontans and all those are the sort of things that if you find that they're pregnant, you start to have chest pain yourself. But the thing that sort of starts that I want you just to notice is that 3/4 of these women were not known to cardiology. So when you get that obstetrician going, this patient's a bit tachycardic and a bit breathless, and you're thinking, oh God, labour ward is nowhere near where I am, and this is probably all rubbish. Just be aware that 3/4 of these women may be undiagnosed and not known. So it is worth going in with quite fresh open eyes and thinking, actually, has this woman got a problem? Because we're always picking up significant problems in pregnancy as the first presentation. Equally, I would say, think about in the last 6 months to a year when you've seen a woman of childbearing age, whether you've thought, if they were to get pregnant, would that be a good thing? So I'm just going to give you a very quick vignette from my hospital, where they all know what I do. I run a big regional centre. I'm always around doing obstetric cardiology as well as everything else. And essentially, this woman came in, 37, out of hospital cardiac arrest, successful resuscitation, witnessed into ITU, intubated, and extubated the next day onto CCU, echo her, ejection fraction 40%. So of course, what's the cause? She has a coronary angiogram because she does smoke a lot and she's from Poland. She has an MRI. It looks like she's got DCM. She has an ICD, and all the medication is started. So absolutely beautiful treatment, seen by lots of consultants, interventionists, consultant of the week, electrophysiologist, counselled about the defib, counselled about everything. But no one said to her, by the way, when you go home, we need to have a chat about sex. Okay? No one did, and 8 weeks later she turns up in my clinic pregnant. And then I just go, okay. And she said, well, no one told me not to get pregnant. So we always assume, so this woman has been through thousands of pounds and lots of complex and MDTs and huge amounts of brain thought, but no one said don't get pregnant. So just be aware, lots of women do not come to you going, I'm thinking about having a baby. Okay, so, I've still got my sunglasses on. It's very sunny out there. So what are the causes of women's deaths? Well, basically, about a quarter die of cardiomyopathy. Most of you think about cardiomyopathy and peripartum cardiomyopathy, But, be aware a quarter of these women die of some form of ischemic heart disease. And that isn't necessarily just coronary artery disease, but spontaneous coronary dissection. So when you see a woman who's 27 with classic central crushing chest pain, who's got some ECG changes and some troponin, don't think, oh, she's 27, that's not coronary artery disease. It can be in pregnancy because it can be scanned. Okay, the sudden adult death syndrome, I don't think we're going to make a significant impact into this because we don't really understand it fully, but these are women who, are found essentially dead with morphologically normal hearts. And then the sort of little bits of things like aortic dissection. Only 4 congenital heart disease. So clearly Kate and the team are doing really well, but that's because these patients are counselled from about the age of 13 about sex, drugs and rock and roll. We tell them what they can and what they can't do. And when they do find they're pregnant, they know exactly what to do and who to call straight away. There are plans in place. So why aren't we doing that for our non-congenital patients? Because there's a lot of them out there that are just as great a risk. Valvular heart disease is disappointingly starting to sneak back in. So, there was a couple of triennial reports where there was no deaths from valvular heart disease, but just be aware it's there. Okay, so last 2018, the ESC brought some guidelines out for the management of cardiovascular disease during pregnancy. There's certainly an improvement on the previous guidelines. The previous guidelines we struggled with a little bit. I think they certainly don't, they cannot account for all cases. So they are really just generic guidelines, and it's worth having a look at. And I'm going to focus some sort of areas that might be useful to you as a non sort of obstetric cardiologist, but just be aware that if you are dealing with a complex woman, you just pick up the phone. There's no other surrogate to just ringing any of us that are in this area and saying, can I have some help? Okay, so what is new? Well, the new concept of the pregnancy heart team. So a bit like all the other heart teams that you've got, and I'm sure you've been learning about those all week, we're saying that women with a moderate to high risk of complications, I'm going to talk about this in a minute, so don't panic, should have their pre-pregnancy counselling and their care in a centre that's got this full team that is available. And they reckon that that's got to be at least a cardiologist, an obstetrician, an obstetric anaesthetist, and in my clinic I've got a specialist midwife and a specialist nurse, and that you've got access to all these other people should you need it. So this is a team of people that are doing this day in, day out. And actually it makes a difference whether it's the really high risk or even things like POTS. No one's going to die of POTS, but when a pregnant woman keeps, passing out or picking up in palpitations and ending up in A&E, the hysteria, the minute the bump is on board, is ridiculous. But having a midwife that just says, yeah, we know, don't worry, is really, really useful. The other things is for some of the neurocardiogenic syncope patients, they drop their blood pressure recurrently, so then it becomes very difficult to pick up preeclampsia. Because, of course, obstetricians, you can have big, you can look like little Michelin women and have protein in your urine, but if blood pressure's normal, they'll be like, what's the cause of this then? It's like, no, it's preeclampsia, but she has NCS as well. So it's just about having a team that can pick these things up. There's a big increased emphasis on pre-pregnancy counselling now. So this is a thing that they're going to, if you think about all of you, so again, whether you're running an intervention, an EP service, whatever, they're recommending to perform a risk assessment in all women with cardiac disease, so that's every woman of childbearing age in your clinic, you should be thinking about pregnancy. Now, I challenge anyone to do that in a general cardiology clinic or a specialist cardiology clinic, but this is what they're recommending to do. But the problem is that means putting the onus on you guys to see for every woman that you see, and obviously with the beauty of IVF and a few celebrity mums, the age of which you can have babies seems to be increasing. We'll leave that one there. So, what is the modified? So this is in your ESC guidelines, so if all of you have got the apps, you can pick this up. So what's good about it, and I'm going to blow it up in a little bit, so don't panic that you can't read it, is it gives you the diagnoses and sort of puts all your different cardiac conditions into sort of levels. It tells you roughly what the sort of risk is of morbidity and mortality. It suggests what the maternal cardiac event rate is, because obviously don't forget there's a maternal and a fetal cardiac event rate. It talks about whether or not they should have counselling, where their care should be during their pregnancy, whether it should be local or regional, and what sort of, how often they should be seen and where they should deliver. So it's beautifully set out that if you have not got the knowledge, you should be able to see these patients and say, give them some generic, sensible, robust advice, okay, without having to be a specialist in this at all. Okay, and this is how the sort of thing breaks down. So the different, we've got a category 2 to 3, 3 and 4. And this is the group where we're saying that pregnancy is essentially contraindicated. This is the group where we're saying that there is such a significant risk of mortality, we really wouldn't be thinking about having a pregnancy, and that either you're going to do things like sort out the mitral stenosis before they get pregnant, or just not have a baby at all. Okay, so it's a really useful tool, and it's a really useful document to have downloaded on your phones or wherever you want to put it, just so that you've got that. So when you see these patients, and obviously if it's a more complex patient, then you can refer them, onto clinics like my own. I know someone just mentioned anticoagulation, so they have brought out these new guidelines with regarding the warfarin doses of, above and below 5, on the basis that anything less than 5 milligrams is a less than teratogenic risk. But you've got to remember that actually, whilst we'll concentrate on teratogenesis, the other issue with warfarin is that the reason the warfarin is teratogenic is because it crosses the placenta. So if it crosses the placenta, it anticoagulates the baby. And therein lies part of the problem. Is we talk about teratogenesis, but the other issue of a lot of these babies is they get intracranial hemorrhage from being anticoagulated. And the minute you say to a mother about any risk of the baby, and that is it, forget it. They just don't want to know. You can tell them all, what might happen to them, and you can draw big sort of goody pictures, and they just don't. They're pregnant, and it's all about the baby then. And so that's the next question I'm going to put to you. I don't want you all to become obstetric cardiologists, because it's certainly something that you need to want to do. But next time you see a patient who is pregnant and who is on warfarin, if they turned up pregnant on Friday night of Easter bank holiday, would they know what to do? Have you got a robust plan in your trust, in your practice, that says, this is what I do, and it all runs like clockwork? Because you're all treating many, many women with warfarin. So these are the sort of things that you can be doing now, should it ever happen. Okay, so just think about these. They do have these flow charts, but I agree with Kate. I don't use them, and to be honest, most of our patients will not use warfarin, and we just end up on low molecular weight heparin anyway. If you are going to be using low molecular weight heparin, whether it be for VTE or for valves, and we all know about the issues with that, just remember that we use the ACS dose, because the creatinine is so low, because the renal clearance is so fast that you have to use basically the ACS dose. So 1 milligram per kilogram BD, for example, in Clexane. So even if it's a PE, you don't use the 1.5. And they're also recommending that you have regular anti-10A levels, and that when they come back, you should have the ability to then change and alter that dose. So you've got to have a little bit of a system set up. With regards to VTE, they're looking at, basically D-dimers are out. They've always been out, but people still suggested you could do them because maybe they'll be negative. They won't be, and all it'll do will stress you when you've got a patient that you didn't think had any sort of VTE anyway. And they're recommending, I think this is a bit more of an American, because I don't know many of us that do that so much in the UK. So there is quite an American flavour to this ESC guidelines. And then again, just saying that if the patients are having PE, have got a PE, then they're really only recommending thrombolytic therapy in severe hypotension or shock. And the main reason is that thrombolysis does not get through to the baby, but obviously there is a risk of maternal hemorrhage. Just a quick mention on radiation, okay? The number of times that women do not have some form of investigation because of fear of radiation. Even things like CT, coronary angiography now, I've done a number of pregnant women and put stents in them, and because of my interest, I've got fetal dose monitors, so I do a little bit of monitoring of the baby just as an additional, and I am not getting any readings that are of any significance at all. Okay, so do not be afraid to investigate these women. Obviously, don't order radiation sort of willy-nilly. But if you're worried about a PE, or if you're worried about a chest infection, or, for example, if they've got chest pain and you would normally take that patient to the cath lab, take them to the cath lab. Do what you would do anyway. It was amazing in the UK obstetric surveillance survey, only 60% of patients with an acute coronary syndrome went to the cath lab. Now, can you imagine taking a young, fit, healthy man and not taking him to the cath lab when he's got chest pain and troponin positive? And yet we did that with pregnant women. Now, why was that? What is it we're stopping? And we think it's the radiation. We don't know because the questions weren't asked. With regards to valves now, they're suggesting that any woman of childbearing age that's going to have a valve is met and had some sort of pre-pregnancy counselling about the implication of that valve in pregnancy. So that's a whole new thing for your surgeons. So be aware that your surgeon should be saying to you, you know, I've been referred this patient from wherever, they need a valve, can you talk to them about the effects of pregnancy? And again, all women with mechanical heart valves should be managed in a centre, in a tertiary centre, because the mortality of these mechanical heart valves is so high. I've had a mortality despite very aggressive low molecular weight, but the patient went a little bit AWOL, forgot to take some medication, and bang, it all went horribly wrong. So even in centres where, you know, we are pretty vigilant, it can still go wrong with these valves, and there's, you know, anything up to a 10% mortality in this group. Patients with aortic disease, they're now recommending caesarean section, and I'm just going to talk about delivery in a minute. And then women with Marfan's or other inherited thoracic aortopathies should have beta blockers throughout the pregnancy. That's another sort of, you know, soapbox moment. So everyone gets very excited about beta blockers and IUGR. That was predominantly from atenolol, and predominantly when you're using atenolol in the first trimester. But the more modern day beta blockers, we're just not seeing the IUGR. We are still doing the scans just to keep the obstetricians happy, and then I can publish it. But basically, we're just not seeing the IUGR. In fact, I had a woman last week who burst into tears because her baby's on the 90th centile, and she said, "Oh, I'm going to push it out. You said it'd be small." So I didn't say it'd be small, but somebody did. Okay, so just be aware. But, you know, one of the, history, you know, it's still on all these sort of the little labels that come out, and, you know, there'll be some pharmacist that goes, "Oh, beta blockers and pregnancy." So please, 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 if you think a patient needs a drug, explain to them why you think they need it, because that's another thing. A number of patients who've been given drugs, that, you know, patients with ICD, you know, who had a lot of shocks, and then went to a local pharmacist and said, "Oh no, you shouldn't be having a beta blocker if you're pregnant." Then of course it gets stopped. Trust me, VF is much worse for a baby than a beta blocker. Okay. The other thing is as well is that they're now recommending that women with vascular Ehlers-Danlos syndrome and don't have a pregnancy because there is such a high risk of dissection. I've completely lost all track of time. Oh, what's that? Is this? I don't know what that means. Okay, pregnancy is not recommended in patients with severe dilatation, and they give you some guidelines as to what those recommendations are. Okay, I haven't got too long to go. So just a quick thing about patients with peripartum cardiomyopathy. So bromocriptine, I don't know if any of you have heard about that. So bromocriptine treatment can be considered to stop lactation and try and enhance the recovery of patients with LVSD. I do offer it to all my patients because I believe in it. I'm a believer. And the reason is prolactin gets broken down, and there is one of the cleavage proteins is pro-apoptotic, and when you sort of feed it to loads of mice, they all kind of ended up with peripartum cardiomyopathy. When you blocked it, they all sprang back absolutely beautiful. We then did a proof of concept study in some human beings, and it seemed to be very effective. All the ones that I've used it in have improved. Now, a third of these women are going to improve anyway, so there is some selection bias potentially. But I have to say, what is the disadvantage? The disadvantage is you can't breastfeed, but to be honest, formula milk is great. And if these women have got severe LVSD, they're not really feeling great anyway. You know what I mean? And it means if they're not breastfeeding, you can get all the ACE and all the other drugs on much quicker as well. So I have to say, I'm a bit of a, you know, an encourager. Okay, the other thing that's quite useful in these guidelines is there's one of these tables. So there's all the drugs that you might want to give, and it tells you whether they're safe or not safe. So it's a lot more useful than the BNF. There's a couple of general concepts. So we're inducing women at 40 weeks now because actually they're doing that outside of pregnancy, mainly because the risk of C-section and stillbirth increases in women. We do still recommend vaginal delivery, so please don't recommend caesarean section. There are some indications for caesarean section, but they're very specific. But we know that vaginal delivery is much better for baby and much better for mum. And it can be done. Don't panic if it happens at 3 a.m. Babies are born outside of hours, and we're used to it. Okay, this is what happens with caesarean section. Okay, but, you know, there was a lot of celebrities that went to have it because it, you know, it was very quick and could sort of book it in, but it is a huge high-risk procedure, okay? And there are things that we can do to make vaginal delivery safer, so we can do early epidurals, we can, once they're fully dilated, I did say I wouldn't talk too much obstetrics, so I apologise, we can just sort of push the baby out, and there's various other things that we can do. So there are lots of things that we can do to make that delivery nice and as normal as possible, okay? Just a couple of key messages. Anyone who's having IVF now should be assessed by the cardiologist. So that's another group of patients that the IVF team are going to be mandated to refer to if they've got known cardiac disease. So again, who's looking after these women? And if you've got a practice, have you got someone that's interested? And if you haven't, can you make somebody interested? Because actually it's much better that 1 or 2 people do it than you will see 1 or 2, okay? And again, because of the WHO class 4 group, that we know that there's a high mortality, therefore they're not allowed to undergo IVF treatment. I'm sure we've talked about ACHD and the fact that we offer them fetal echoes because of the transmission and genetics. And again, we always try and make a delivery plan in this group to say that if they do have premature delivery, which is not uncommon in this group, that wherever they end up, someone knows what to do. Again, remember about heart failure, you know, use the same sort of drugs apart from in the non-pregnant woman, so we still don't use ACE inhibitors predominantly because of the renal issues. And again, even conceiving on an ACE inhibitor gives you a 7 times increase renal risk than if you don't. So just be aware, again, when you give someone a 41-year-old hypertensive, an ACE inhibitor, have you counselled them that should they become pregnant, they need to stop it or they need to find an alternative? So we're giving all these drugs out all the time to women with childbearing age, and we're not thinking if they got pregnant on that drug, what would be the implications? So again, just think about that in your general cardiology practice. And again, we do recommend that these women, if they have a pregnancy, there is a likelihood as their LV function will deteriorate. And as such, we do recommend that those who have peripartum cardiomyopathy, that a subsequent pregnancy isn't recommended if the LV doesn't normalise because of the fact that they just really do not very well. If a woman needs a drug in an emergency, please give it to her, okay, because the mother always comes first. So yes, all the inside leaflets will say do not use in pregnancy because that's what they have to do to get their FDA stamp. But basically, if you need it, please give it. All right, the mother always comes first. Okay, galloping home. So they're quite good guidelines for the management of heart disease and pregnancy, and they give you some, some generalised management ideas. I think there's a big increase focus on pre-pregnancy counselling, so that's something that you all need to be thinking about if a woman asks you whether it's okay to get pregnant. But even if she doesn't ask you, have a think. If this woman was to be pregnant, she rang me tomorrow and was pregnant, would I be delighted or terrified? If the latter, you need to be giving her some counselling. Okay. There are some pregnancy heart teams around the country. Find out where your local one is. Give them a call. You know, they don't even need to be local. I often get phone calls from all around the UK for people that have been to a lecture like this, jotted my phone or number down or email, and then just, gave me a call. We're always happy to answer questions. We talked about the updated anticoagulant guidelines and a little bit more pharmacotherapy advice. Any questions? That was a bit of a gallop through, and I do apologise.
Thank you, Dawn. So if you just stay at the podium for a little while, because as I say, we're not going to do the panel discussion. We've done direct questioning to the individual speakers to try and just keep us on to the programme time. So I guess we'll just take some questions from the audience here. Chapman over, I think, first with his hand up. Are you okay?
Always.
Gin and tonic on the train on the way back.
It's not really a last point really, but a couple of times I've had calls from delivery suites and local hospitals. I've been on the intervention on call, and it's sort of my heart sinks because I know very little about pregnancy-related complications, and it's been very time, midnight, 3 in the morning, 2 in the morning. Can we use carbocross in this patient? She's bleeding to death. Clearly, it's quite an easy decision to say yes,
yep.
But it's got me thinking. I really don't know who to call if it's not an easy question. Is there an on-call rota for the country of people to call out about?
I've got a number if you want it. I'll give you it.
Okay, so in answer to that, actually, I normally put my number up. I am actually happy to be called by anybody out of ours. I know I'm a bit nerdy, but it's what I do because actually there aren't that many phone calls. We are looking at we have set up this new UK Maternal Cardiac Society for people that are interested, and this is going to be one of the things we're going to be thinking about, whether we do a sort of telephone service for that. There isn't one at the moment, so you just need to find somebody local or friendly, or just not so local but friendly, but you're absolutely right. The other thing is you just do what you have to do, because in an emergency, medico-legally, there is no question. If you try to save the woman's life, that's fine. That is all you've got to do. You know, all these drugs might cause these issues and might make that issue worse. But you know what? We'll manage that as and when. And exactly what happened to you is why I'm in obstetric cardiology. Because I think there's someone up there that I recognise that I was working for. Is that David at the back there? Hello. I was working for this gentleman when I got a phone call at 2 in the at 2 in the morning to go and see someone on labour ward, and I hadn't a clue what to do. And she'd phone in from wherever, South Africa, and was in acute pulmonary edema with everything going wrong. And I felt very uncomfortable. I was at the Hammersmith, I didn't know what to do, and I was like, I don't know what to do at all. And I struggled. And so yeah, that's what got me into it. Fascinated.
More questions? Lady at the front.
Slightly off topic, you talked about D-dimers in pregnancy. Do you have any experience with using the years algorithm in D-dimer range to diagnose PE in pregnancies?
No, none of the scoring systems, the modified Wells, all of these things, none of them have ever been used in pregnancy. So none of them are. You've got to just go back to good old clinical basics, I'm afraid. But your D-dimers are going to be positive anyway. So just don't use them because they're just no indication whatsoever. They're not helpful at all. But on the caveat to that, troponin is normal within a pregnancy. So if you have got a raised troponin, it's real. There are some papers that say preeclampsia puts your troponin up, and it does, but it puts it up, but not to the level that would normally cross to make you a positive troponin. So if your normal range is 15, it might be 0 to 5 in a non-pregnant, and it might be 5 to 15 in a preeclamptic, but it doesn't cross the threshold that makes you think this is positive. You know what I mean? Unless they're in pulmonary edema from the preeclampsia.
I just got two questions. First is regarding the peripartum cardiomyopathy. The women, though, most of them, they do recover in my practice. So do you continue the heart failure treatment lifelong, or can they come off the treatment and then so that they get pregnant again and then again?
Again and again and again. Yeah. Okay, so yeah, there are new rules. So my personal practice, and I know Kate looks after some of these people, so if Kate does anything different, we can talk about it. So my thing is once they're over their pregnancy and their heart has normalised, I tend to keep them on the medications for at least a year. Because I feel that they've had an insult, and also we'd never advise a pregnancy in any less than in a year in a normal woman, because everything's got to heal up. And then what I tend to do is see them at that year and re-echo them, or MRI, depending where you're up to in the sort of investigations. And if the LV is completely normal and they want to have another baby, then or even it's not, then what I do is I stop the medication for 6 months, and then I re-scan them to make sure that normality isn't because they're being held by the medication, but they've actually fully recovered. And then if they are still normal, then I counsel them that this could reoccur and ... But yes, does that make sense?
Yeah. Do you use echocardiogram or CMR for the LV function to be fine?
I mean, we tend to CMR them at some point, because one of the problems with peripartum cardiomyopathy is we, as you know, it's a new diagnosis and no other cause. But what we still don't know from these patients is it an early DCM that actually was just subclinical, and then the pregnancy then sort of brought it to life. So I often do at some point postnatally. And the other thing is a lot of the changes of pregnancy can take anything up to, they're normally all done by 6 weeks, but some can last a little bit longer. So personally, I tend to do an MRI at some point, but so I'll do an MRI, and then if the MRI is answer me, then you can serially manage them just with echo. They don't need to have serial MRIs just to check the LV function.
So you stop them like the beta blockers, no ACE inhibitors or anything like that?
So I'll keep them going for 12 months, and then if everything is entirely normal, then I will stop them, and then I will re-scan them at 6 months. So always make sure that there's a re-scan after, just to make sure that, and that the heart isn't being held. Do you do the same? Yeah, Kate agrees.
It's like the TRED-HF paper, wasn't it, in DCM, where they took them off the medication and a certain percentage.
Yeah, because some of them, exactly, there's a reason we give these people medication. So it is important that you explain to them why. And I also make sure that they don't get pregnant in that 6 months, because then if their LV goes down again, you then don't know whether it was the lack of medication or, the pregnancy again, all this kind of stuff. And then if you're saying don't get pregnant, then you've got to advise on contraception. Because...
No, somebody else, because there's lots of other questions in the room. Or there was some other questions, yeah.
Sorry, just my tuppence worth from a tiny unit with regards to peripartum cardiomyopathy. But I think John just made one of the points I was going to make was that you take some people off medication just to see, and you hope it's all going to get right, but certainly there's evidence about Takotsubo that's come out recently that people do deteriorate even though you don't expect them to. So my personal practice now is to keep people on it for longer. And my reading of the literature again got about a 50% chance of recurrence in a subsequent pregnancy. If it doesn't recover, it's about 100%. So about, you know, the few I've had to cancel, which is single figures, I've said, you know, the chance of this happening again is 100% because your vegetable's not available.
And that's absolutely right. And that's why it's leave it 6 months, re-scan them, re-counsel them based on that. You're absolutely right. Yeah, you can't talk to these people enough. But that want for a second child is huge. I've suggested they have mine for a day. That will put them off.
One more quick question. Gentleman at the back.
Sorry. Have you ever had a case of endocrine in pregnancy in your practice? And if yes, can you share your procedure?
Yeah, so I had a case of endocarditis on a VSD. So I think then what you've got to do is basically a lot of the antibiotics thankfully can be used in pregnancy, so that's okay. And then it's really about getting the baby to viability and then getting the baby out. And so that, you know, most neonatal units now will offer you 100% survival at 30 weeks. There's a little bit of ADHD risk between 30 and 34, but actually, you know, well mum, well baby. So, you know, then it's really a case of limping them along to sort of 28, 29, 30 weeks. And again, you need to give them a shot of steroids because then they've got to have fetal lung maturity, and that then increases the baby's survival risk significantly. And that's going to be important because the baby obviously could be septic too. So, yeah, and then it's just a case of standard management.
Fantastic. I think we'll stop there. Thank you very much, Dawn. Hope it wasn't too traumatic.